Next talk will be about chemical injury review of chronic management. It will be given by Dr. David Gritz.
I'd like to thank the organizers for this invitation. I'll make a disclaimer that these are going to be the ugliest slides you've seen during the conference, but hopefully you'll get something positive out of the talk. I have no conflicts of interest. Almost all these treatments are off-label, and in fact, whenever you look at the evidence basis of how we treat this, all of the studies are either C or D evidence. But nonetheless, we need to treat these patients. They need aggressive treatment and do our best for them. Immediate treatment is very important. Aggressive irrigation, both on-site, whenever the patient first has the injury, even if it's just with whatever fluids are available. And then once the patient gets to the emergency room, using either a Morgan lens or just irrigation in general, having the patient look in all the different directions, sweeping the fornices so that you make sure you get out any particles there, maybe even removing the particulate matter at the slit lamp, and then monitoring the pH to make sure you've brought down the pH to a normal level. During the pandemic, there has been a great increase in the number of people who have had alcohol-based sanitizers get into their eye, and one of the problems with that is it's not only the alcohol, but it also has a very alkaline pH. Also, whenever someone gets this in their eye, the kind of that viscous fluid can actually hide in the fornices, so it's important to sweep the fornices, not only just to irrigate, but also sweep the fornices to get all that out. In the acute treatment phase, the grading with either rope or hole or the DUA scales is helpful. Basically, the bottom line in both of those is that if the patient has more than a third to a half of limbal ischemia, they have a guarded to very poor prognosis. And when you look at the outcomes for patients, the patients who have very mild burns generally do very well, and the patients who have bad burns do very poorly, despite even the most aggressive treatment. Then the goal is to control the inflammation, get the surface to heal, prevent symblepharon scarring, and address any glaucoma that may be present. In regard to treating inflammation, corticosteroids are usually our first line. In the past, there's always been this teaching of only 2 weeks of steroids. And when I went back and reviewed the actual original study by Dr. Donchik and Dr. Dolman, it was actually an animal study in rabbits. And I am very unimpressed with the recommendation that came out that we should only use steroids for 2 weeks. Their point is that steroids decrease epithelial healing and inhibit the collagen synthesis. But also we know that inflammation decreases healing, inhibits healing. Of course, we have to have respect for side effects of steroids. We don't want to over-treat the patient with steroids. But we also need to appreciate the benefits of steroids in helping to control the inflammation, helping the eye to heal, and helping to decrease complications that can occur also. This is the case where using a more potent steroid, difluprednate or maybe dexamethasone, may be helpful because then you don't have to use the drops as often, because certainly this is a case where we're trying to limit toxicity and encourage the healing. Ascorbic acid, either systemic, 2 grams 4 times a day, or topical 10%, if you have that available, can be helpful. You do have to be careful of using high doses of vitamin C in patients who have renal failure. Citrate 10% has been said to help. Topicals, if you have that available, has been said to help. Doxycycline is part of the standard treatment we often use because it inhibits the pro-inflammatory cytokines, including the metallic proteinase inhibitors. Metallic proteinases. You obviously have to avoid doxycycline in pregnancy and in patients younger than 12 years old. And then the goal is to get the surface to heal, get the surface to epithelialize, because that's really a huge part of your goal in the initial therapy, because then the other complications that patients have will dramatically decrease once you get the surface to heal. Aggressive preservative-free lubrication. If you can get autologous serum tears made very quickly, that can be helpful, or other blood-based therapies. We now have the Regenisol, the Genesis and the Regenerize that are part of the amniotic membrane extracts and amniotic fluid extracts that are available commercially. Those commercial names should be down in the final bullet point. And also there's something called finger prick autologous blood, where the patient just does a finger prick. They clean off their finger with an alcohol wipe, let it dry fully, prick the finger, and then you actually put a drop of blood in the eye. And that's been shown to help in patients with severe dry eyes and may be helpful in patients where you don't have autologous serum or platelet enriched serum available, drops available. And then to get the surface to heal, but also to prevent symblepharon. Amniotic membrane surgery has been shown to help with that. There's actually a nice study that showed that if you use a symblepharon ring and glue, that's actually more effective than using sutures for amniotic membranes, where you take the amniotic membrane and actually suture it into the fornix and a suture at the limbus. But that was actually shown to have more symblepharon formation than just a symblepharon ring and glue. Procare is something people use a lot. This is a therapy that, although theoretically it should be very helpful, there's not been any studies that compare Procare to just a basic bandage contact lens, and certainly there's a much greater cost. The nice thing about Procare is it does kind of have that symblepharon ring, although it's not a large ring. It's not like a large ring like the traditional symblepharon ring that really goes further into the fornix. Glaucoma is often overlooked in the initial stages because you're so worried about everything else you see going on. But high pressures can happen in up to 15% of the acute cases, and the incidence of glaucoma in alkali burn patients increases over time. The goal is really to control the pressure, but also limit the ocular toxicity. And the reason why glaucoma happens is not just can be just the damage that happens from the alkali injury to the trabecular meshwork, as well as the inflammatory mediators that happen. But then you also have to, there's also this balance of like, is this from the damage or is this from the steroids? Doctors and patients are often very quick to blame steroids instead of the disease. So we have to be careful that we don't cut back on the steroids too quickly, thinking that it's just the steroid response. Novel agents that may be helpful include the recombinant nerve growth factor, topical insulin, acetylcysteine. In the chronic treatment phase, the goal is still inflammatory control, either with topical steroids, but also systemic immunosuppression may be helpful in those patients. Systemic steroids initially, but then followed up by medications such as mycophenolate or cyclosporin are two of the agents that are often mentioned. Fornix and eyelid construction be helpful. So that can either be by buccal mucosal graft or from nasal mucosal graft. People are also working on growing cells outside the eye and then using those to help repopulate the surface. Limbal cell stem cell deficiency is one of the challenges of these patients because that leads to conjunctivalization of the cornea and opacified corneas. And then a autograft corneal clarity can be restored by either PKP or DALK, and don't forget to address the glaucoma. In regard to limbal stem cell transplantation, this is not for acute treatment. This is only after the control of inflammation. And the question is autograft versus allograft. If the patient only has one eye affected, then autograft can be a very effective way to address this. If patients have both eyes affected, then parental or sibling or another relative may be helpful as using as a donor because there'll be more genetic similarities. The other choice is an allograft, but systemic immunosuppression is important in those situations. In a large systematic review, they found that conjunctival limbograft and simple limbal transplantation were the best outcomes as compared to ex vivo expanded cultivated limbal epithelial transplantation. And the good news also in this review was that it's this, whenever you do the autograft from the other eye, it's safe for the donor eye. Future therapies, people are talking about stem cells, either chemoadipose or mesenchymal cells. Angiotensin converting enzyme inhibitors have been shown to increase the conjunctival reestablishment of microvasculature. Antifibrinolytic agents may be helpful. Bezuclismide or VEGF inhibitors may be helpful for decreasing corneal neovascularization, but it's this kind of challenge of restoring vessels so the eye is not ischemic, but also inhibiting the corneal neovascularization. Thank you very much.
Thank you, Dr. Gritz.